Thank you for giving us the opportunity to present our work today entitled Concurrent Retropubic Midurethral Sling and OnabotulinumtoxinA for Mixed Urinary Incontinence, a randomized controlled trial. This study was generously supported by a grant from Friends of Prentice. The authors have no other relevant financial disclosures. We conducted a double-blind, randomized controlled trial looking at retropubic midurethral sling with concurrent OnabotulinumtoxinA injections compared to retropubic midurethral sling with placebo injections for women with mixed urinary incontinence. Recruitment was from March of 2016 to November of 2019. Our inclusion and exclusion criteria are listed here. At the first visit, all recruited patients underwent multi-channel urodynamic testing and completed baseline demographic surveys as well as the UDI-6, PFIQ-7, PGIS for overall urinary incontinence symptoms, stress incontinence symptoms, and urgency incontinence symptoms, and a 3-day bladder diary. Subjects were randomized on the day of surgery. During surgery, the surgeon placed the retropubic midurethral sling in the operating room and cysto was performed prior to incision closure, at which time the intravesical injections were done. Either placebo, which was normal saline, or 100 units of OnabotulinumtoxinA was injected. These were identical in appearance. After surgery, the standard retrofill postoperative voiding trial was done in the PACU, and all subjects were discharged on the day of surgery. Postoperatively, patients were seen at 2 weeks and 3 months. The surveys and bladder diary were repeated at 3 months. The patient global impression of improvement for overall incontinence symptoms, stress incontinence symptoms, and urgency incontinence symptoms was also added at 3 months. Adverse events were collected. Our primary outcome was whether women with mixed urinary incontinence undergoing retropubic midurethral sling had greater improvement in overall incontinence symptoms when intravesical OnabotulinumtoxinA injections were added at the time of surgery. The measure we used was the PGII score at 3 months, where a response of very much better or much better was designated as improved. Based on our power calculation, we required 68 participants. Secondary outcomes were incontinence symptom severity measured by the patient global impression of severity at 3 months, quality of life measured by the pelvic floor impact questionnaire, and adverse outcomes. We recruited 78 patients, 41 in the OnabotulinumtoxinA arm and 37 in the placebo arm. There were no differences in baseline demographics, survey data, or bladder diary data between placebo and OnabotulinumtoxinA study arms. There were no differences between groups in surgical variables. And of note, there was no difference in median PVR at 2 weeks between groups. All survey scores and bladder diary leak counts improved from baseline to 3 months in both groups, indicating improvement in incontinence symptoms and quality of life. Our primary outcome, which was improvement in overall incontinence symptoms from baseline to 3 months post-op measured by the PGII, showed no difference between groups, with 83% of the OnabotulinumtoxinA group reporting improvement and 84% of the placebo group. On the PGII for urgency symptoms only, however, on a scale where 1 was very much better and 7 was very much worse, the OnabotulinumtoxinA group had significantly greater improvement in urgency symptoms compared to the placebo group. Similarly, on the PGIS for urgency symptoms only, where urgency symptoms were ranked in severity from 1 being normal to 4 being severe, the OnabotulinumtoxinA group had significantly less severe urgency symptoms at 3 months than the placebo group. When looking at adverse events, there were no statistically significant differences between groups. Between 2 weeks and 3 months, more women in the OnabotulinumtoxinA group, 12%, compared to 3% in the placebo group, required self-catheterization, but this did not reach a statistical difference. Similarly, 22% of the OnabotulinumtoxinA group and 5% of the placebo group had a culture-proven UTI at 3 months, but again, this did not reach statistical significance. At the 3-month post-op visit, 3 women in the OnabotulinumtoxinA group and 1 woman in the placebo group were found to have a mesh exposure along the suture line that was less than 1 centimeter in size. These were all managed expectantly with local vaginal estrogen therapy and did not differ statistically between groups. In conclusion, women with mixed urinary incontinence undergoing retropubic midurethral sling report significant improvement in overall incontinence symptoms regardless of the addition of OnabotulinumtoxinA. Women receiving OnabotulinumtoxinA in addition to midurethral sling had greater improvement in urgency symptoms and less severe urgency without a significant increase in adverse events, including urinary retention at 3 months. Thank you, and I welcome your questions.